Hi everyone, my name is Netta Shami and I'm delighted to be here to speak to you about IOL selection in post-refractive eyes. These are my relevant financial disclosures. As with any surgical patient, I think the first step to success is to really spend the time with the patient to lay down the expectations and share with them the obstacles you may face in reaching the goal that you both will have for their success and a 20 happy patient. I think it's important for you and the patient to understand the challenges faced in achieving refractive emmetropia or the refractive target due to inaccurate IOL calculations, as well as the fact that the visual system in a post-refractive eye may be compromised, especially if they are post-RK or they had laser during the early generation with the early generation lasers. All in all, the goal is to find the right lens that not only matches the patient's visual needs, but also their optical system. We have already talked about all the different ways of combating the inaccuracies in corneal power calculations. The limitations of keratometry and topography are multifold, and it really stems from the estimations made that really do not take into account the changes in the cornea as a result of refractive surgery. The advanced imaging devices do offer expanded data sets, all of which have been very helpful in, again, coming to a number that is more reflective of the true corneal power, as do all the different IOL calculation formulas that thanks to all the brilliance of our colleagues, many of whom are faculty in this very stellar program, we've been able to again have more assurance that the lens we do choose may very well get us to where we need to be. But having said all of this, we still have to speak to the patient about the risk of a refractive surprise and the possibility of plan B, be it laser enhancement or even an IOL exchange. This is further compounded by all the different wonderful variety of lenses that are available to us that allow us to offer our patients spectacle independence. And who better to offer this to than someone who invested a lot of money in having refractive surgery to have spectacle independence to begin with. These patients come in expecting that and hoping for it. And obviously, though, unfortunately, the success of these lenses often rely on us being able to hit that refractive target. And as I mentioned, that tends to be a moving target in our post-refractive eyes. Furthermore, glare and halos and loss of contrast may be innate or inherent to many of these eyes. And if we further add to that by implanting a lens such as a multifocal or an EDOF lens, it may result in an unhappy patient. I have not hesitated implanting these in the right patients, and we'll talk about which ones are, but I always share with the patient the risk of and the possible need of explanting it if necessary. Now the question is, more than a decade of effort and resources and intellect and a whole industry has risen out of the insecurities of going into cataract surgery in these patients who have had refractive surgery. What if we take all of that energy and minimize it and put it where it really would give us much more predictable outcomes in the post-op period? What if we could implant a lens and have a kind of a ballpark idea of what power to implant, get it close enough within 2 diopters of our target, and be able to make adjustments after when the lens has been stabilized in the capsule and its lens position and the refractive outcome has been stabilized to a point where we know what our target would be. Well, that's exactly what we get with the light adjustable lens. I've had a lot of fun working with this lens, especially in my post-refractive patients. This is a lens that can be implanted, as I mentioned, and then after about 2 weeks after surgery, adjustments can be made, up to about 3 or 4 adjustments, and then the lens power is then locked in. The amount of adjustment that can be made is up to 2 diopters in either direction of sphere and about 2.5 diopters of cylinder. Imagine that. Again, none of that concern or fear of the refractive surprise. That is not even a concern in these eyes. Again, ideal for post-LASIK and PRK. It's great for patients who are wary of glare and halos. Now, let's get to practical terms here. What if then next week you have a patient that comes into your office, gives you the history of having had refractive surgery in the past, and is now interested in cataract surgery? Probably the most important question to ask is how happy they were after their refractive surgery. If they tell you that for 10 years they enjoyed excellent vision and only recently have developed glare and halo, that tends to really manifest itself in a topography that often is quite regular with a central ablation, as seen here in these types of patients in a post-RK, post-hyperopic LASIK, or post-myope, and these patients tend to have clear corneas. Light adjustable lens is still the best option in them, because even with this type of predictable measurements or semi-predictable measurements, we can still get refractive surprises. But if you don't have access to the light adjustable lens, I think in a post-myopic LASIK with this appearance in their topography and with the history mentioned, a monofocal or a toric with a negative spherical sphericity would be a reasonable option. In a post-hyperope, though, again, I would point at LAL as a great option. I would go more for a neutral SA lens, such as an LI61AO. That's true for the post-RK. As far as if they wanted maximal spectacle independence in a post-myopic LASIK with this type of topography and history, I don't hesitate offering an EDOF lens or one of the newer lenses, the extended depth IOL. In a post-hyperope, I'm more hesitant unless the patient is highly motivated. I then consider, again, an EDOF, but I'd rather not. And in a post-RK, I really try to veer away from multifocal lenses. Here is my first patient that I implanted in LAL, was a patient who was post-RK, and look at those refractive outcomes. Their vision, uncorrected vision, is 20/20 plus in both eyes with minimal refractive error. It's also really important to recognize patients with compromised corneas or optical systems. These are patients who had refractive surgery but tell you their vision was never good after. They tend to have irregular astigmatism, decentered ablation zones, ectasia, ocular surface disease, and typically have higher order aberrations. These are cases that can do well with the light adjustable lens. That would be my go-to lens. But I would also consider, again, a neutral monofocal lens in these eyes. I would absolutely avoid multifocals and EDOFs in these cases. Now, toric can be implanted in a post-ectasia if the central cornea is mostly regular. So the take-home message is utilize a variety of diagnostic modalities to arrive to the best estimate. Anticipate next step. If left with a refractive surprise, talk to the patient about the possibility of a lens exchange or laser enhancement. And consider the light adjustable lens. It really has lessened the anxiety in addressing problems and refractive surprises in these patients. And finally, consider the extended depth of focus IOL for spectacle independence in the right patient. I thank you so much for your attention, and I look forward to discussing about this topic further in our discussions.
Okay, great. Now we have our panel discussion. Thank you guys for those excellent talks. I feel like these are such important areas as clinicians, corneal disease, external disease, and then also the post-refractive patient. These are things we see all the time. Let's start with screening for ocular surface disease. Each one of you here are, believers in treating ocular surface disease. And I think that sometimes we get a little overwhelmed in all the options, or what should we do? Each of you, I'd love for you to share, what are you doing currently to screen for ocular surface disease?
Okay, I can go ahead and start. I think your talk was really spot on. I do like osmolarity as the initial screen. It certainly gets us to start thinking about it, as well as patient surveys about symptoms of dry eye. I think the one test that really is important that I think is not well used is meibomian gland imaging. MGD is the most common form of all dry eye. And it's really underdiagnosed. The meibomian gland imaging can not only alert you to MGD, but it's very educational for the patient, because all patients think dry eye is aqueous tear deficiency. When you start to talk about MGD, they get confused. But if you can show an image of gland dropout, they start to understand it. So, those tests are important. And then your mnemonic of looking at the lids, lifting the lids, pushing meibomian expression, again, is a good way to look for MGD. And then corneal staining, and my comment about corneal staining, if you use one stain, you should use lissamine green, not fluorescein. You know, if we're trying to diagnose dry eye with fluorescein looking at epithelial defects in the central cornea, that's not really dry eye. That's severe dry eye. You know, lissamine green will pick up stain in the disease conjunctiva where the cornea epithelium may be normal. So I guess 2 points: add meibography and think about lissamine green as screening for your cataract patients.
I'll add just, go ahead, Nana.
I would also add that looking at the corneal topography, as Ed was saying, it's really important, as is looking at the Myers. Often, you know, you have patches of loss of data on the corneal topography, but you may not. And I think looking at the Myers and how jagged those, you know, the rings are, that's also another way to demonstrate to the patient how the ocular surface is very irregular. And that's, for me, has been really important. And it's surprising to me how much we've talked about topography and imaging devices. There's a lot of surgeons who don't rely, or they don't have access to topography. And I can't imagine really moving to the next level of utilizing the advanced technology lenses without having that information available to us.
Those were three great talks. And you know, one thing that's sort of the poor man's way to evaluate is to ask the patient, not so much do you feel ocular surface discomfort, because we know the majority are asymptomatic, but to ask them if they notice visual fluctuations, because even if they don't feel discomfort, they will notice, you know, moments when they, you know, blink and they see better. And so that's always an indicator. It's one of those few always in medicine that there's ocular surface disease.
Everyone's made great points, and I think it can be challenging on what to do. There's no wrong answer, but the key is to be suspicious of dry eye on every single cataract patient. I love pushing the eyelids and seeing how the meibomian gland secretions look. You can pick it up. I do use fluorescein, looking more at tear breakup time, but I agree that if it's staining, it's even later. And then, of course, as Nana pointed out, topography and making sure all the signatures of magnitude axis lines up with your biometry. If there's discordance, it tells you that there's dry eye.
Yeah, I think that's a great point, Bill. You know, we're getting a lot of tests standardly for our cataract patients, topography and biometry. And, you know, you can use the tools that you already have integrated into your practice. I think adding a questionnaire is a really simple thing that requires no surgeon time. How many, you know, in my clinic, sometimes hours, you know, how many minutes are there of dead time where the patient's waiting to see you? Those are things that can fill time and space, but also give you a lot of information. And as we heard in John and Steve's talk in the beginning, these are really important things that we need to be screening for and getting information from our patients. So I want to move on to some of our corneal disease, because I think this is also, you know, a lot of what the ASCRS algorithm was trying to do is identify not only dry eye, but other causes of ocular surface disease. And so we brought up ABMD, Salzmann's nodules, but then it's also important to look thoroughly at the cornea and look for Fuchs dystrophy. I mean, how many times have you seen a patient referred in unhappy after a premium lens and they have early Fuchs dystrophy? You know, so things like that happen. And in my clinic, one of the things I sometimes struggle with is, you know, that patient that has corneal disease. The patient's there for you to have a cataract surgery, and you sort of feel like you want to do the most optimal treatment. But how do you talk to the patient about treating ABMD or, you know, Salzmann's nodules prior to surgery? How do you set their expectations, and when do you feel that it's essential to do that?
You know, Priya, I think the most important thing is to inform the patient prior to cataract surgery. You know, if the patient has subtle EBMD and you decide, you know, it's not that big of a deal, you do the cataract, patients ends up with 20/30, 20/40 vision, and then you go back and you talk about it, it's almost like they don't believe you. You know, you didn't mention this pre-op, now they're blaming you, the surgeon, that you did something wrong. So I have discussions all the time about EBMD and Fuchs dystrophy, And of course, these are two diagnoses that are very foreign to patients, may have been missed by the referring optometrist. And now, not only do you have to talk about cataract, but you have to then inform them they have a cornea disorder as well. But the key is setting expectations pre-op by explaining in detail. And then you have to decide, are you going to manage it, prior to surgery, during surgery, after surgery? And it really depends on the extent of the disease and whether it's going to affect your visual outcomes.
I fully agree with that. And I think imaging is really important, and not just topography. And obviously an ABMD would be really important to in deciding whether or not you need to address it if it's affecting the central visual axis, but also digital imaging. I have an iPhone attachment to my slit lamp. It's very easy to take images and showcase it to the patient. And nothing will be more telling than you can spend a lot of time explaining what the condition is, but until they see that image, it's really hard to get that across. And with Fuchs dystrophy patients, I think it's really challenging, especially in those patients whose Fuchs may, as Ed was saying, there may not have that much corneal edema, or corneal thickness is within normal range, but they have that confluent beaten metal appearance to their guttae. And a lot of times these patients are not happy with just cataract surgery alone. But I think telling them ahead of time that this may happen and that we would take the next step if necessary, and targeting about a -0.5 or -75, depending on which corneal surgeon you refer to, because of that hyperopic shift that can happen later. So that's really important also to communicate with the patient.
Amazing. We have just 1 minute left in our discussion, and Netta, I really wanted to talk about post-refractive eyes. So you each have 15 seconds to give me your number one thing, or one or two things that you look at in post-refractive eyes to decide if you're going to even talk to that patient about, multifocal or EDOF lens. So I'll start. Mine is I look at the topography and I look at its centration as the first thing I look at. So, all right, let's go down the line. John.
High order aberrations, total corneal high order aberrations above about a 0.5, and most post LASIK, certainly all post RK patients won't meet that criteria.
And what are you using to measure it?
That's, you can do it with a number of devices, but I use the Zeiss Atlas topographer.
Cool. Bill?
I love topography. Pentacam is what we have, but you're looking for the centration, as you pointed out, and the smoothness in that optical zone, if they're a good candidate or not. And I think that's key.
Perfect. Ed?
High order aberrations, topography. I don't like multifocal IOLs in these patients. I think EDOF lenses are okay. I just see too many unhappy multifocal patients for post LASIK.
Wonderful. Thank you guys for such an amazing discussion. We are going to move on to our last two talks of the session, which will be followed by a panel discussion. And then of course we have our breakout session. So our next talks are going to be by Dr. Nathan Radcliffe. He's talking about glaucoma and pseudoexfoliation in our premium patients, followed by Dr. Steve Charles, who'll be talking about macular evaluation.
Hello, this is Nathan Radcliffe, pleased to be speaking about refractive cataract success in patients with glaucoma and exfoliation. I am pleased to work with a number of companies within the cataract and glaucoma space. We can see a variety of potential problems with cataract extraction in patients with glaucoma, loose zonules, poor dilation, synechiae, iridectomies, history of trauma, and in some cases even vitreous in the anterior chamber before the cataract surgery has even started, are all on the menu when it comes to taking cataract out in patients with glaucoma. Small pupils are another common hurdle for cataract surgeons when taking care of glaucoma patients. And of course that can be because of previous laser procedures, previous glaucoma procedures, but also from diseases such as pseudoexfoliation or even medications, the miotic class being a common offender. But the main rule that I want to focus on a little bit here is making sure that your patient is an excellent candidate by assessing the foveal vision. That's the most important part. And so here I'm going to show you the most important part of this visual field is dead center. The most important number on this visual field test is the foveal sensitivity. Normal is above 30. Why is it so important? Well, someone with 2400 vision could have a normal field and a foveal sensitivity of 0. In my practice, above 28 is very comfortable. 32 is perfectly normal. Once you're in the 25 range, you can assume the patient won't see normally after cataract extraction. So here's a patient with damage in the central visual field. These are 10-2 visual fields in both eyes. I have to take her cataract out. Is she even going to see? We can answer that. And the answer is yes, she'll see probably 20/20. Her foveal sensitivity in the right eye is 31 decibels. In the left eye, it's 33. Maybe not a multifocal IOL candidate, but someone who can see very well. And this information helps us tell the patient what to expect. Here's a patient where I myself almost took the cataract out, 20/40 vision, presents with the full visual field. What's not to like? Well, I was a little bothered by the 0 decibel foveal sensitivity, and so I went and got a central 10-2 visual field, which revealed a very deceptive paracentral scotoma, superior and inferior, foveal sensitivity still 0. Let's look at the OCT. Well, in fact, there's advanced glaucoma, retinal nerve fiber layer damage, in both eyes, and indeed we see macular loss in the right eye, almost complete, and in the left eye we see foveal splitting with a ganglion cell analysis. Glad we got the OCT, glad we assessed the visual field, glad we looked at foveal sensitivity before promising this patient an excellent outcome. My next rule is that nailing the target is unfortunately tougher in glaucoma patients. This paper from Leo Seibold at Denver shows this in a very nice way. He looked at a bunch of patients who had undergone cataract extraction retrospectively, and he found there were more refractive surprises by a half a diopter or a diopter in the group of patients with glaucoma compared to just normal eyes. And he found that POAG, chronic ACG, and exfoliation were all had a higher odds of refractive surprise, but really exfoliation was the one that knocked it out of the park with an odds ratio of 7.3 compared to non-glaucoma eyes of having a refractive surprise. Interestingly, a previous trab or tube did not correlate with any refractive problems. Well, what about MIGS? Well, MIGS are great for visual acuity. In fact, in these two studies, the iStent G1 study and Vold's second generation iStent inject study, the group that got cataract surgery plus a stent ended up having slightly better vision than either the ones that got cataract surgery alone or the ones that got travoprost. Why would that be? Well, we know the drops interfere with best corrected vision and stents don't. So that's a good go ahead. You can in fact use premium IOL technology with a stent in appropriate patients. Now, Ray Brown showed us that toric IOLs work exceptionally well in glaucoma, and I think this is intuitive to us all, but he showed basically that he can get all of his patients to 20/40 and even more than half to uncorrected 20/20 with a variety of toric IOLs. And in fact, when we looked at residual refractive cylinder, really most even had less than a half or a quarter diopter of CIL, even with some with severe glaucoma and a toric IOL. So that technology is good to go. Here is a patient that I saw who was referred to me having had an angle procedure with a cyclodialysis cleft. It was 360-degree cleft. And so I was able to visualize a cleft on gonioscopy. And, this patient, as you'll see, had a premium IOL, a small cleft. I made a small dissection in the conjunctiva after identifying and marking the cleft, and simply put a tenoproline suture through the ciliary body, ab externo, tied a knot. You can see blood in the anterior chamber because the needle did, in fact, close off the cleft. There's the proof. I put a little glue down just to close the conjunctival incision, and I tried to come my best to do a cyclodialysis repair fitting of a patient with a premium IOL. And, in summary, I think you can see a few things here. Advanced technology lenses can be used in glaucoma patients with normal foveal vision. That's the key. You have to look and you have to know it's normal foveal vision. Nailing the refractive target is priority number one, but it is tougher in glaucoma. Good data for excellent visual outcomes with MIGS. I didn't go down the whole rabbit hole of eye drops, dry eye, and how that thwarts refractive outcomes, but yeah, I think we know that story and we should pay attention to it. We have strong data for success with toric intraocular lenses. We use traditional glaucoma diagnostics carefully to identify the best candidates. Bumps in the road are possible, but we really, at the end of the day, shouldn't deprive our glaucoma patients of this amazing technology if they're appropriate candidates. Thank you very much for listening. It was a pleasure speaking to you.
Hi, I'm Steve Charles. I'm going to talk to you about